that concludes our very first Joint Medical Forum, and I hope you've enjoyed it and found it informative and inspiring. I'd like to thank our distinguished guest speakers who have all brought so much to today's meeting, and without whom, of course, we could not have carried on. Just bear with me, I have a few more points to make. One is that lunch will be served in the urban kitchen directly when we finish. That's one floor up, and our speakers will be delighted to speak to any or all of you and give you any further information. Secondly, the Khalifa Foundation is making a small video recording, as you can see. If any of you would be prepared to participate in an interview, they will take place just outside of a few minutes duration. And thirdly and finally, tomorrow evening you are all invited to the Fish Market Restaurant, 7:30, and please speak to my colleague if you would like to come. You know that you can come, all our speakers will be available. And if you have any colleagues who you feel would have liked to have been here today, that it's appropriate for them to come, that you would like to bring with you, please also let us know that. So in conclusion, thank you very much indeed, ladies and gentlemen. Most of all, thank you all very much for coming, and we hope you've had a productive
different types of doctors to really provide what we need to help contribute to our mission. So some of our fellows, some of our graduates become true masters of clinical oncology, and they're broadly trained to see patients with breast cancer and colon cancer and leukemia and lymphoma, etc. And every year, of the 14 fellows we train, 3 or 4 of our fellows will become these true master clinicians, and they will have outstanding clinical skills. They'll have broad and deep knowledge in both internal medicine and in oncology and hematology. We have clinical investigators. These are people who do research, and their patients are their research subjects. We encourage our fellows to get formalized training in clinical investigation, so I provide the resources so they can get a master's degree in clinical research. They also are encouraged to have some exposure to laboratory research while they're doing this, and they apply for different grant support so they can design a prospective clinical trial, etc. We have physician educators. Now, physician educators are a rare breed, I guess I would say. But about once a year, one of our fellows per year will be very interested in physician education. And I actually think that's an important thing for people from UAE, from graduates from UAE, to think about coming to us to become educators and to come back and educate the future generations in oncology and delivering outstanding oncology care. And these people also have a lot of strong fund of knowledge, and we usually expect them to have their research projects or their projects in education and how you educate people to be medical oncologists. The last group is physician scientists. This may or may not be something that you folks are interested in, and these are people who have laboratory-based careers, but they're intended to take their research discoveries directly into patients. And they're both scientists and physicians, and they're taking discoveries from the laboratory to the bedside and then back to the laboratory bench to learn how to make for better treatments. And as I mentioned, we have a lot of time for research and other scholarly activities. People can become experts during their fellowship in the treatment of leukemia, in the treatment of breast cancer, sarcoma, etc. We also have a lot of our fellows participate in clinical research. For example, 2 of our fellows currently, just to give you an example, are looking at new drugs for something called BRAF mutated colon cancer. This is a very poor prognostic situation where if you have a mutation in the BRAF oncogene, you have very difficult and highly resistant colon cancer. MD Anderson is really getting into immune treatments for cancer, and one of our fellows is working hard on the immunotherapy of kidney cancer. We have people who do what's called health sciences research or outcomes research. How many people who need adjuvant therapy for their cancer among underinsured actually complete the treatment as prescribed by their doctor. This is important, and then we can find what are the barriers to completion of adjuvant therapy, which is delivered to patients with curative intent. And as I mentioned, we also have opportunities for laboratory-based research as well during our fellowship. So I think in terms of the options for training in medical oncology for graduates from UAE medical schools, we could offer broad training in medical oncology. This would really take, I think, a minimum of 2 years. We would deploy them on our first year of clinical rotations that I described earlier. And then in the second year, we would allow them to participate in a variety of ambulatory clinics. We have a large number of conferences where we can do a lot of learning and teaching. They could help us write case reports and participate in quality improvement projects within MD Anderson. We could also provide options for UAE graduates to really become subspecialty experts to staff the cancer centers in UAE. To me, this would take a minimum of 3 years. Would be, again, clinical rotations, and then in years 2 and 3, there'd be really more focused work in a specific disease site: breast cancer, melanoma, prostate cancer, leukemia, etc. So in summary, I think there could be real value to training at MD Anderson. We have a large number of patients with a wide variety of malignant conditions. We have world-class clinical experts and world-class laboratory-based researchers. We have significant resources to help train our fellows and other trainees. We have a lot of grant support from our federal government. We receive more federal research dollars than any other cancer center in America. We have very generous donors, to include the Khalifa bin Zayed Foundation. And we, specifically in medical oncology, really have the opportunity to provide great training and help produce master clinicians, clinical investigators, and physician scientists. And I think importantly, clinical educators who could help be sort of teach the teachers and then let those teachers train the workforce over here. So with that, I'm going to open it up for a few questions in terms of specifics about training in medical oncology. And then my colleague, Dr. Vaporjan, will talk about surgical oncology training. Any questions about what I've talked about? Yes. I can hear you. I'll repeat your question. Not at the present time, but that's a great question. That is something we've started to ask. We have an international cancer center, and so we're trying to start to track patients that come to the international center, both in terms of their demographics, their risk factors. We haven't done specifically isolating them for genetic profiling, but certainly they're going to have access to that. But that is something that would be very interesting to see if the mutational spectrum is different among Emiratis or other Arab backgrounds as part of that. And this again is why you want people to come. You know, there's more work to be done than the people we currently have. And that would be a great project for somebody to come and look specifically at the outcomes and the genetic profiling of patients with tumors. Dr. Al-Shamsi is trying to get his hands around patients with colon cancer from the Middle East, and do they have different clinical variables and outcomes compared to our domestic patients, as an example. He's doing what I'll call a subspecialty fellowship. So he's already trained in medical oncology. He's now with us for the next 1 to 2 years to become an expert in GI cancers, to really develop subspecialty expertise in colon cancer, liver cancer, pancreatic cancer, and to use that expertise here in the UAE to help deliver better treatments for patients, do clinical research here. So I think the number one issue there is it's my sense, because I haven't really been to different sites here, that there are going to be graduates from your medical schools who are qualified to participate in residency programs in the United States. I don't think there's any question about that. There are some hoops they have to jump through. They have to pass certain exams. They have visa requirements, etc. That part, I think, is something we think is doable, that there are going to be qualified graduates from UAE who can come and do residency programs in the United States, specifically in Houston and at the Mayo Clinic. I think the broader issue is that's a commitment of 3 years for residency in internal medicine, 5 years, I think, for general surgery. And then to do fellowship training on top of that in oncology is a minimum for me in medical oncology of 2 years just for broad training, 3 years for subspecialty training. And so now we're talking about 6 to 8 years of commitment in the United States with visas, and then with the plan to be trained and be a real expert and come back here. That's what I don't know if we're going to have that many graduates from UAE medical schools who say, I'm willing and I want to commit 6 or 8 years in training in the United States to come back home and really become an expert that helps develop a critical mass of great teachers and clinicians and researchers to do the work. This is why, and I think there are going to be some people who are interested in that, but this is why I think we need to talk in terms of observerships as well, is that people may say, I'm willing to go to the United States for 4 months, 6 months, 3 months, 1 month, and at least get a sense of how we approach different diseases in the United States without committing 6, 8, 10 years of their life to that kind of training. To me, this is the fundamental issue. I don't have a sense that there's going to be an issue with qualifications. Again, there are these requirements, but I think it's really more about how many graduates are going to be committed to that kind of time investment. Other questions right now? Right here. So that's a great question. So what I would say is one of the issues here is what is expected for UAE in terms of board certification. All right. So if you want to be board certified in medical oncology by the American Board of Internal Medicine, they expect people to have residency training in the United States and then their fellowship training in the United States. If UAE says, the government or the accrediting bodies here say, we don't really care if they have board certification in the United States, I think we're going to be in a position to offer fellowship training to people who've done a residency in internal medicine or general surgery in UAE, and then come and perhaps have a tailored fellowship experience in the United States. That's something we can discuss, but again, it depends on what you folks want in terms of a board certification. To me, if they have residency training, you know, I know that the ACGME, right. So with that in place, I think it's a lot easier for us to say these folks have gone through an accredited residency training program, and that we can accept that into our fellowship programs as well. The issue is just, are they board certified in that area as it pertains to American boards? If that's not a major issue, then I think we can take people from these residencies and train them in oncology in our program. And that would be more like 2 to 3 years. Again, it depends on, do you want to have people with good broad medical oncology training, gynecologic oncology training, whatever? Do you want really to develop some subspecialty expertise beyond that? And that's just a matter of how much time they're going to be in the United States. Yes, sir.
Nephrologist, transplant nephrologist by training, trained in Canada and got my US and Canadian certifications. I'm Chief Academic Officer for our health system, the government, Abu Dhabi Health Services company. I think in addition to the general information on fellowships, what we lately tried to explore with a number of academic medical centers in Canada, US, and UK is if we could define a bridging program that takes people from, let's say, A to B, because we do know about the intake and how our graduating residents or even medical students have to compete to get into residency or fellowships. But the gap is how do we take them through this bridging period, and we don't have the intention of them getting special treatments. We want them to be more informed about what it takes for them to successfully compete. For example, with some academic centers, we discussed them joining perhaps a year in advance to join maybe a research year, but during that research year, they could also be exposed to what it takes for them to pass their licensing exams. With others, even an observership period could be more structured. With a particular Canadian university or health system, we planned on an PLP, personalized learning program objective, in which they would be taking an active part to simulation centers. They would be actively evaluated to see are they fit enough to be considered for a fellowship. So I think we can, hopefully in the next few days, I know you will be visiting a number of Saha hospitals and others. You will meet some of our graduating residents. If we could work together to define a bridging program, then hopefully this helps many young residents and fellows and new graduates know what it takes to match in MD Anderson and Mayo Clinic, because we are interested to give you qualified candidates, because they have to obviously be taking care of patients and they have to be responsible. But yet we found that if we offer our graduating residents time to accustom to what it takes to be successful in the US, then they can give the longer term commitment.
Yeah, I think that's a great idea, and that's certainly something we can be happy to talk about. MD Anderson is an oncology center. Having said that, MD Anderson is part of a broader Texas Medical Center where we have UT Medical School in Houston. We have Baylor College of Medicine there. We have Rice University. We have a number of academic centers. And I think we can provide this sort of, I guess I would call it academic building and sort of a preparatory period of time to make them very, very competitive for residency training or fellowship training within our system. Yes.
Does this program as well provide opportunity for student exchange program to be there so that they will put them in a track to see exactly how the system works there, and it will enhance their desire to go and complete their further studies post-graduation?
So I think that's a great question, and when I talk about, you know, one of the things that I have found, because we receive, well, we have people in our program who are international graduates. They've gone to medical school outside the United States, and they've come to a residency program in the United States, and then they come to our fellowship. Many times the letter of recommendations from the residency program says, this resident initially was behind their colleagues because they didn't know how our system worked. But once they caught up, once they figured out our system, then they very quickly caught up to their other colleagues who were US trained in medical school. And so this idea of during medical school to have an opportunity for people to come to the United States and immerse in our healthcare record system, how we do rounding, how we do our patient care, I think could make people not only more comfortable when it's time for residency training or fellowship training, but also, again, as you say, to inspire them. This is a wonderful learning environment. I'd love to come here for my residency training, for my fellowship training. So I think at the medical school level, to come for 3 months, possibly 6 months, you know, that would be something that we would have to talk up with the medical universities here about allowing medical students to come. Whether they come to Houston, to Rochester, and really just immerse in the culture of sort of Western clinical training may inspire many to be more comfortable with the idea of coming to the States for their training. So I think that's a good idea.
Actually, our student does have a program of 2 months when they are 6-year students to go abroad. And they are try to apply for American institutes, but sometimes with a great difficulties. But if we have a bridging with you people and then we can make it, then it will be the most wonderful experience for them to go. And they are willing and they are sponsored by the university for such an activity.
So my view is this is why we're here, to talk about developing a true partnership with the Mayo, with MD Anderson. So it's not they're trying to get into the U.S. system. We're going to open our door to MD Anderson, to the Mayo, to allow for that. To me, again, the issue is how many people want that experience and are willing to make a commitment of time that may be quite substantial afterwards.
May I ask one more?
Of course.
The other question is about, we have a lot of people who have finished their medical school. They have finished their internship. They are not yet decisive about their decision where to go. And would it be an opportunity that to come for kind of a same kind, or during their application for USMLE and ECMG, so that they can have their kind of passing their tests during that period to have an attachment and to be even appearing for exams there? It might make it more easier. Would that be an opportunity as well?
Yeah, I mean, I can't say yes for certain, but before I made this trip, we started to talk to the people at the University of Texas Health Science Center, the medical school in Houston, about their opportunities for residency training. But I think this idea of coming for a year in preparation to take the USMLEs is something I think we could establish with Texas Medical Center partners. I don't have a lot of concern that we couldn't work that out. Other questions? I'm going to turn it over to Dr. Proportion.
So thank you very much. Bob asked me to come to speak about surgical oncology training. You just heard about medical oncology training, so I'll admit that I'm a thoracic surgeon, which in the United States means I'm a cardiovascular and thoracic surgeon. There's no distinction, but I'm going to try and cover all of surgical oncology as it explains to GYN oncology, head and neck surgical oncology, all the way up and through thoracic surgical oncology. Also wanted to thank you because this sort of collaboration is something unique. I'm actually an associate editor for education, and I'm one of those physician educators that Bob mentioned. I actually am pursuing a master's in education, so this is something very passionate to me, and the idea of bringing together different cultures and different groups to discuss and compare and contrast is something that I think needs to be done more often. In fact, at our national meeting in about 4 months, I guess we're going to be in San Francisco, we have a globalization of cardiothoracic surgical training as a program. It's a 4-hour program discussing just this idea. How can we globalize training of cardiothoracic surgeons? And of course, that's applicable to all the fields, not just cardiothoracic surgery. But I think this is a need that's going to become much more common as we go forward. So this is the evolution of a thoracic surgical oncologist. As Bob mentioned, the total time it takes is roughly 15 to 19 years of medical school training, starting with an undergraduate degree. In my example, it took me about 3 years to get my undergraduate degree. I then had to pass a summative exam, the MCATs. I then went to medical school for 4 years. And then throughout medical school and the year after, we take 3 separate USMLE exams, as you know. And then I did my general surgery residency, which was 5 years of general surgery training. There are in-training exams at each year throughout those 5 years. In the middle of that, I broke off for 2 years to do laboratory-based research. And then at the completion of general surgery, I did my 2-year fellowship in thoracic surgery, which was, as I said, both cardiac and general thoracic. So it's not specifically a thoracic surgical oncology. For general surgery, the track is almost exactly identical, except they do have a surgical oncology fellowship that has now been ACGME approved. So there's a clearly defined 2-year fellowship in surgical oncology. This is a bit in evolution. They only became ACGME certified last year. This is their first year. Many of the programs were 3 years in length. They've now curtailed it down to 2 years. But there are also a vast array of subspecialty fellowships, much like Bob was mentioning about colorectal and breast. There are similar colorectal, hepatobiliary, breast, endocrine, all surgical oncology subspecialization fellowships for 1 year each added onto this. So they could be 15 to 20 years in length to get their training. The problem with surgical oncology is it's already broken up into multiple different disciplines. I mentioned thoracic and general at the top with 7 to 8 years of training needed after medical school and undergraduate training. Head and neck surgery has their standard 1 year of general surgery plus 4 years of otolaryngology, followed by a 1 to 2 year fellowship specifically in oncology. Similarly, urology has the same plan. GYN, of course, has to do OB-GYN for their standard 4-year residency, following which a 4-year fellowship in GYN oncology. And they're a bit unique in that GYN oncologists also administer chemotherapy. So unlike all the other surgical subspecialties, the GYN oncologists are also administering the chemotherapy. And then orthopedics as well has 5 years of orthopedic general training, followed by a 1 to 2 year fellowship in orthopedic oncology. Those last 4 disciplines, all of that oncology fellowship training is really not ACGME approved. It's not an accredited ACGME. These are all outside the ACGME system as fellowships, which makes them much more malleable and much more able to be incorporated into some sort of US or foreign training paradigm. I think those would be easier. The general surgery and the thoracic, because they are rigidly defined by the ACGME, are a little bit harder, and we can talk about that a little bit more as I move on. So what does the training program at MD Anderson look like? And for that matter, the training program at any institution? Well, all training programs must have a curriculum. That's sort of the roadmap for any educational system. Bob described their curriculum, and I'll sort of go through what it takes to build a curriculum in thoracic surgery as the example, although this is similar for all the surgical subspecialties. There are many different sort of flow diagrams that show a curriculum. This is the one that I use. Really the main two objectives here at the front, you have assessing the needs of the trainee and then setting the goals and objectives. And then you have to determine how you're going to teach them and what you're going to teach them. And then you actually have to do the teaching. And then at some point you begin to need to assess the trainee and make sure that they've achieved those learning objectives that you set out for. And then in the end you do a summative exam, and if they're educated, great. If not, you repeat until they're done. So surgical training in the United States is what we call a multi-tenant system. There are multiple different forms of thoracic surgical training, for example. There's not just one standard. The ACGME in the United States, and I sit on the residency review committee for the ACGME for thoracic surgery, they actually have approved 4 different tracks to become a general thoracic or a cardiothoracic surgeon in the United States. MD Anderson uses a 2-year model. That means 2 years of additional training after 5 years of general surgical training. Now, you don't have to be board certified in general surgery to enter into our training program, nor do you have to do that across the United States, but you do need to complete an ACGME approved general surgical program. Now, with the new international ACGME, and as I said, I sit on the board, or I sit on the ACGME, I've heard the lectures by Dr. Nasca. I don't know if our boards will now accept IACGME as well, but my assumption is that there will be some laxity in that, and there will be the allowed movement of an IACGME approved fellow into a ACGME approved thoracic training. Other training programs are 3 years in length. There's also an integrated program where you do essentially 5 years of general surgery, but one of those years in general surgery is dedicated to cardiothoracic surgery, and then in the same program you do an additional 2 years, so they call that a 4-3. And then there's now a new training paradigm in the United States called an integrated, so straight out of medical school you can go directly into cardiothoracic surgery, and there are now 28 positions in the country for that. And that is heavily attracting foreign fellow trained medical students, because there is no requirement for an ACGME approved general surgical training before you move into cardiothoracic surgery. The problem with that for this audience is that the majority of those training programs are guided towards cardiac surgery, with very few, if any, focused on general thoracic or thoracic surgical oncology. So the people who set up these sort of paradigms and oversee them are 2 different groups. There is some sort of a physician credentialing group for thoracic surgery. It happens to be the American Board of Thoracic Surgery. And then there has to be a group that credentials the program. And again, for thoracic surgery, that's the ACGME. Both of those programs actually play different roles. The physician credentialing board is really the one who defines what the final product will look like. They're the ones who come up with the learning objectives. They're the ones who say these are what qualifies a competent general thoracic surgeon in the United States. And their primary allegiance is to protect the public. They are not there to help the thoracic surgeon in training. They are there to ensure that the public's needs are met and that the public is safe, and that we are not graduating physicians who could harm the public. On the other hand, the program accreditation function held by the ACGME for us is there really to look at the process of training and to make sure that the training programs that are accepting trainees have all the necessary attributes to fulfill the needs of the credentialing board. A new system that's just been put in place in the last 2 years is called the Next Accreditation System, and now they've gone beyond focusing on simply the process, and they're actually beginning to focus on the outcomes as well. And they're putting in the assessment tools and the metrics so that they can say that you are, when you are finished, you have hit all of those functions. So now the two groups, the credentialing board as well as the program accreditation board, are doing in concert. They're looking at the outcomes. So I think these two groups really hit the goals and objectives, and they hit the needs assessment for us. And as I'll continue the example of thoracic surgery, we have a set of learning objectives that were given down to us by the American Board of Thoracic Surgery. In addition, the American Board of Thoracic Surgery gave workforce members, along with other societies, to produce what are called the milestones, which is what the program accreditation of the ACGME is using for their outcome measure. So those two things, the learning objectives and the milestones, are really the predominant objectives of our training programs. In addition, they lay down operative requirements. All trainees must do certain numbers of specific types of cases during their training. And if they don't meet those numbers, they cannot sit for their board certification. There are also some requirements laid down on the number of patients that have to be evaluated during their 2 years of training. There's also some requirements on the types of rotations they must participate in. As Bob showed, there has to be a certain period of time spent on benign hematology. Our trainees are required to do senior level experience in both cardiac surgery and general thoracic surgery. There's also some requirements for simulation. Our trainees must participate in 20 hours of simulation, which is a pretty mediocre requirement, but at our institution we've taken that and they do roughly 20 hours a year. And then there is a requirement for scholarly activity. All trainees must do some form of scholarly activity between their 2 years of training. So those really define the needs and the goals and objectives. The next step is the instructional methods. And in this area, the United States really is still focused predominantly on clinical work. Clinical work is really the predominant way that teaching is done in the United States for our training programs, and that's no different in thoracic surgery. And the instructional materials are predominantly the patients and the cases that come into the clinic. Now, there's other things as well. For instructional methods, we use role modeling, we use readings, we use lectures, we use simulation. We have a curriculum embedded within our residency training program, which is a 1-year repeating curriculum. Our residents meet for 2 hours every Friday morning. They are either run through a didactic lecture with oral exam sort of format, or they do a simulation exercise, or they have a mock oral examination in preparation for their main oral exam that they do at the end of their 2 years. The teaching materials are predominantly textbooks and articles, and they're predominantly coming from the library, from our PubMed. And the primary form of teaching is, as you see in that diagram, really hasn't changed for about 100 years. It's an apprenticeship model, and it's a similar model that's used all across the world. Most of the responsibility for designing the actual teaching is done at the program level, the individual training programs. However, national societies, and we have the Thoracic Surgery Directors Association, the Society of Thoracic Surgeons, and the ATS also contribute, as well as industry. One of the main problems for our trainees, and I imagine it's a problem all across the world, is an ever-increasing volume of information that our trainees have to tackle and have to understand and sort of wrap their heads around. As you can see there, those are the total citations in Medline. They are increasing at roughly 1 million per year, and it's an exponential growth. It's been increasing 7% per year since the foundation in the 1940s. We now have over nearly 23 million publications in Medline. It's impossible for a trainee to wrap their head around all that information. So one of the things we've done at the society level is we've tried to curtail that and define it for our trainees. If you imagine this box represents everything that we think our trainees should know in some particular aspect of training, like say lung cancer, what they could do is maybe find one article that covers one element of that need, maybe another article that covers a different aspect of that need, and so on and so forth. You'll find that there's thousands of articles here that would cover this area. Some of them would overlap, some of them would hit aspects of lung cancer care that are beyond the needs of our trainees. So what we felt we needed to do was to sort of curtail that, to remove those articles that are unnecessary and focus it down to absolutely what our trainee needs to learn in the 2 or 3 years they spend with us. And we did this at a national level. And what we did is we developed a number of systems to do that. The first one here is our content management. We brought together a series of experts across the country, and we defined exactly what is needed to be learned in each of the various aspects of thoracic and cardiovascular surgery, and we place it on this website. It's been available now for about a year and a half to our trainees. In addition, we organized it into a learning management platform that you can see here, where we arranged it into courses and topics. But the point was that in order to get some sort of uniformity across the training programs in the United States, we put together this sort of a system so that the trainee knows that they can go to this website and the articles that are present there are what the American Board of Thoracic Surgery and the ACGME in thoracic surgery all feel are necessary for learning. Then you get to the teaching and the assessment portion of our curriculum. And here again, most of that responsibility falls on the individual training programs. They get some guidance through the American Board of Thoracic Surgery, as well as through the Thoracic Surgery Directors Association. We have an in-training exam every year. In addition, we do global assessments, we do direct assessments all throughout the year. My trainees are assessed at least 2 to 3 times each week, going through their entire training program. In addition, they're assessed every month by the nurses, by our mid-levels, our physician extenders. They're assessed every 2 months, sort of globally, by all the surgeons and the faculty. And all this is summarized at every 6-month intervals and then reported back to the ACGME, which is part of the next accreditation system. But this sort of constant feedback to our trainee helped them find their gaps and accelerate their learning so that by the time they're done in 2 years, they'll hit their needs. And then finally, there has to be some sort of continuous program evaluation. When I first took over as program director at MD Anderson for our Department of Thoracic Surgery, we actually got site visited every year continuously for 6 years. And the reason wasn't because there were citations. The reason was we were making changes every single year to our training program, and the ACGME needed to come in and mandate that our changes hadn't affected our training program. And the reason we were making those changes was we were discovering gaps in our training program. And I think any training program is going to have to do that continuously. And now, despite being run by the individual training programs, also the next accreditation system with the milestones is really facilitating that and sort of operationalizing this sort of program evaluation. So in the end, I think sort of the 3 main components to our training program is this national organization and oversight that comes through the American Board of Thoracic Surgeons and the ACGME. I think as Bob alluded to, I'm very lucky. I have 7 faculty in my group. They're all very interested in education. I can ask any of them to lead an endeavor and they will do it for me. So I think that's the other component, is having that core group of educators. And then finally, I think one of the key elements, at least in surgery, because it is so heavily a technical discipline, is you need an appropriate volume and distribution of clinical cases. If you can't see all the different clinical cases, then you can't be trained surgically. I think it takes all 3 of those components together to really produce a qualified surgical oncologist. So, thank you.
Good morning. My name is Belinda DeBose, and I'm a project director in the Department of Medical Education at MD Anderson Cancer Center. I'm here representing for our VP for Medical Education, who unfortunately couldn't be here. And in my former role, I worked with her managing the GYN Oncology Fellowship Program. So my assignment here is to talk about requirements for residency and fellowship programs. And before I do that, I'll just give a brief overview of the medical education process in the U.S. leading up to fellowships. So becoming a physician is quite a long road, including 4 years of college, after high school to earn a bachelor's degree, then taking the MCAT exam and attending a attending a 4-year medical school, and then applying for a residency program, which is approximately 3 to 7 years. And then for those wanting to go into subspecialty training, they would go apply to a fellowship program, which is yet another 3 to 7 years. So in contrast, most international schools only have on average a 6-year medical school program offered to students straight out of high school instead of college. So combined residency and fellowship training, as Dr. Wolf and Dr. Vaporshian pointed out, could be anywhere from 3 to 7 years or longer. So basic medical requirements for medical school include the medical college admissions test, which is also called the MCAT exam. Students must also have 1 year of biology, 1 year of physics, 1 year of English, and 2 years of chemistry, including organic chemistry. Do U.S. medical schools accept international students? Absolutely they do, but it's not easy. Only a small number of international applicants are accepted. So, for example, in 2012, of a total of 45,266 applicants, a little over 1,700 of them, or 3.8%, were foreign students. For the first time enrollees to U.S. medical schools in 2012, out of a total of 19,517 matriculants on the medical application process, you can visit the Association of American Medical Colleges website. And this information that I've provided here is also available in some handouts that I have that are outside. So where can the MCAT exam be taken? Well, the exam is administered several times throughout the year at numerous U.S. locations and also at some locations abroad. For a complete list of the countries and specific testing locations, one can visit the AAMC's website and then go to the MCAT homepage. And just to note, the exam is always administered in English, regardless of the country in which the exam is taken. So let's talk about residency as it relates to the international medical graduate. So an international medical graduate is one who received his or her basic medical degree or qualification from a medical school located outside of the United States and Canada. The international medical graduate must be certified by the Education Commission for Foreign Medical Graduates, also called the ECFMG. And this is prior to having any patient contact in the U.S. The application process is usually a 3-step application. Also, there's one more step that I didn't include here, which is the USMLE. But the ECFMG is one component that is different for foreign medical graduates from that of U.S. medical school graduates. The other component here is ERAS, which is the Electronic Residency Application System, and that's the application to which applicants apply to residency programs. And then once an applicant applies and maybe they're accepted for interviews, they then rank the programs to which they're interested in applying, and then programs also rank the applicants that they're interested in bringing to their programs, and this is done through the National Residency Matching Service called the NRMP. So let's talk about the ECFMG. The ECFMG assesses the readiness of graduates of medical schools outside of the U.S. and Canada to enter U.S. residency and fellowship programs that are accredited by the ACGME. ECFMG certification is a requirement for international medical graduates who wish to enter such programs. But ECFMG certification does not guarantee acceptance into programs, and it is required for U.S. medical licensure testing. For the examination, applicant must have a past performance on medical science and clinical skills examinations, and this includes the USMLE Step 1. The Step 2 USMLE exam includes 2 components. One is the clinical knowledge exam, and the other is the clinical skills exam. To be ECFMG certified, one must also meet the medical education credential requirements, which includes completion of all requirements for the medical diploma, a receipt of a final transcript, and also verified credentials by the ECFMG. Just a few tips regarding the ECFMG. One should gain knowledge of the ECFMG requirements no later than the 3rd year of medical school, and actually they should be encouraged to gain knowledge at the beginning of medical school. Applying for the USMLE Step 1 and Step 2 exams is through the ECFMG, and for the time limits that are required for completing the exams for the ECFMG certification, one can always refer to the ECFMG information booklet that can be found on the ECFMG website, at www.ecfmg.org. And again, this information is in some handouts that I provided. So about the USMLE exam. One must have completed 2 years of medical school before applying to take any part of the USMLE Step 1, Step 2 Clinical Skills, or Step 2 Clinical Knowledge exam. These tests can be taken in any order, but Steps 1, 2, and 3 must be passed within a 7-year period. Now, MD Anderson has an institutional requirement that each step must be passed within 3 attempts. For finding a residency, applicants can always contact the residency or fellowship programs directly to apply for a position. And also there's information available at the AMA website. There's FRIDA online, and there's also a graduate medical education directory called the Green Book. And there's resources there for applicants to find out information on the various programs that are accredited by the ACGME. So for applying to residency, all international medical graduates must undertake residency education in the U.S. before they can obtain a license to practice medicine in the U.S. Applicants can apply directly to programs by using ERAS, which is the Electronic Residency Application Service. And ERAS usually opens in September and October of each year. ERAS transmits the residency applications, the letters of recommendation, and all other support documents to the residency program directors directly via the internet. Program coordinators from each residency program can then access the ERAS system and check the applicant's request. Usually each program has an admissions subcommittee that reviews each applicant and their supporting documents, and then they decide on the candidates that will be invited for interviews. So programs select candidates to interview based on the following. They'll look at their USMLE test scores, they'll look at previous clinical experience, recommendation letters, research accomplishments, and also community service or volunteer work. Applicants are then invited for interviews, and interviews are generally conducted in November, December, and January of each year. And then I mentioned the National Residency Match Program. So within that system, applicants after interviews will generally rank the programs that they're interested in going to, and then programs likewise will rank the applicants that they're interested in having coming to their programs. And then a rank order list is submitted in the National Residency Match Program. And in February, the rank order list is usually submitted. And in March, Match Week begins when applicants learn whether or not they are matched to a program. And residency training usually begins July 1 of each year. So for applying to fellowships, individuals applying for admission into any one of MD Anderson's full-time GME residency or fellowship programs must have the following: a Doctor of Medicine degree or its foreign equivalent, a valid ECFMG certificate. They must be able to obtain an appropriate visa, either a J1 or an H1B, and they also must be able to obtain a physician in training permit from the Texas Medical Board. Just a note, MD Anderson is now tobacco-free, so in an institutional effort to encourage good health and to remain true to our mission to end cancer, MD Anderson will begin tobacco-free as part of its hiring and appointment process. GME trainees who will begin training on or after July 1st of 2016 will be subject to the institutional tobacco-free policy. Urine testing for drugs and tobacco compounds is required for all individuals who are appointed to MD Anderson, regardless of citizenship. So a candidate who does not pass the urine drug screening cannot be appointed at MD Anderson, but they can apply the following year. But if they do at that time, there's no guarantees that they will be appointed. An application to fellowship is very similar to the application process for applying to residency programs. We encourage applicants to go to MD Anderson's website, which is www.mdanderson.org, go to our schools and programs site, and there go to the graduate medical education and find the residency and fellowship programs, where you can find eligibility requirements for each subspecialty specific program. Discover is an electronic-based application system that is used for most programs, but some programs also use ERAS, and again, that's the electronic residency application system. And once again, candidates are usually invited for interviews by an admissions subcommittee, and after interviews, applicants will generally enter their rank list in the NRMP, and programs will also enter their candidates in the NRMP. And depending on the subspecialty program, the match will take place. So the minimum document requirements that must be met before an applicant can be considered for appointment are 3 letters of recommendation, an official medical school transcript, the USMLE Flex, Specs, or Comlex exam transcript, and score reports are not acceptable. The programs will want to see the official transcript that shows each attempt that the exam was attempted. They'll also want to see a letter of good standing from the current clinical training program and certificates from all completed internship, residency, or fellowship training programs. An ECFMG certificate, if applicable, and also translations of documents that are not in English. So IMGs who are not citizens or permanent residents of the United States must be able to obtain J-1 visas sponsored by the ECFMG or an H-1B visa. And they must meet the eligibility requirements for the visa, which will be sponsored. And it's encouraged that applicants submit these visas well in advance of the anticipated date of enrollment. Now this chart lists the differences between the J-1 and the H-1B visa, and I won't go over everything, but just to highlight a few points. The J-1 is, the regulatory oversight for the J-1 is provided by the U.S. Department of State, and for the H-1B, regulatory oversight is from the U.S. Department of Labor. MD Anderson sponsors the H-1B visa, and the J-1 visa is sponsored by the ECFMG. Both the J-1 and the H-1B visa, for eligibility requirements, the applicants must have valid ECFMG certificates. The applicant must pass the USMLE Step 1 and both components of the Step 2 exam for the J-1. And for the H-1B, in addition to passing the USMLE Steps 1 and both components of the Step 2 exam, they must also pass the Step 3 exam. Both for the J-1 visa and the H-1B visa, applicants must qualify for a physician in training permit. And for the H-1B visa, in addition, they must provide credential evaluation of the MD degree. If it was awarded by a medical school outside of the U.S., they must provide a copy of the MD degree in English, and then provide evidence of English proficiency. The time limit for a J-1 is not to exceed 7 years, and for an H-1B is 6 years maximum. The processing time for a J-1 visa is 8 weeks to secure the Form DS-2019 from the ECFMG, and then an additional 1 to 2 months to obtain the J-1 visa from the U.S. Embassy or Consul. And for the H-1B visa, one must allow 3 to 6 months for processing the H-1B petition, and then an additional 3 to 6 months required to obtain the H-1B visa. MD Anderson has a Visa and Immigration Services Administration office that's responsible for processing all non-immigrant institutional visa-sponsored applications. And you can call this number at any time for general questions related to visas. And I've provided the number here, and also it's available on the handout. So MD Anderson does offer, through our global academic network, other opportunities. such as the observer programs. So by definition, the observer program is a limited experience. It's watching and listening only with no patient contact, no clinical or research activity, cannot provide service, and no access to systems. So it's basically a hand-in-pocket experience. One of these types of programs is called STEP, and this is for appointments that are 5 days or less. The application process involves the applicant contacting the department of choice at MD Anderson to determine availability of observer positions. The applicant must be accepted by a department and then recommended for appointment. And then an application must be completed, and the application must be submitted directly to this email address, which is steprequest@mdanderson.org. Departments then provide the applicant with check-in instructions based on their established procedures. This type of appointment, credit is not granted for this type of appointment, and also certificates will not be issued. And the processing time is within 10 days of receipt of a completed application. We also have observer opportunities with minimum appointments of 6 days to a maximum of 90 days. And regarding the application process for this type of observer opportunity, an application must be submitted through Discover, which is the electronic-based application system. A permission letter is required from the home institution, and some programs will charge a department fee, and that varies by program, anywhere from $200 to $500 per week. Applicants must also be able to secure the appropriate visa for the observer appointment. Travel arrangements should not be made until an official appointment is given by the processing department at MD Anderson. And then again, the department will provide check-in instructions based on their established procedures. Credit is not granted for this rotation. Certificates will not be issued for these rotations, and stipends are not available. The processing time, applicants are encouraged to apply no less than 30 to 60 days in advance of their desired appointment, and applications will then be processed in approximately 15 days upon receipt of the completed application, plus another 5 days per processing time to review the visa. So the B1 visa is typically recommended for observer programs, but MD Anderson's visa office will review each application on a case-by-case basis, and this is as well as for the J1 and for the H1B visas as well. And then they'll make recommendations for the best available options. The B1 application is done online using a form DS-160. Applicants are required to upload the following documents: a passport, an application fee receipt, and a photo. And then an interview must be scheduled through the U.S. Embassy at the location where the applicant is applying. And again, if anyone has questions regarding the B1 visa, you're encouraged to contact our visa office, and the number is provided on the handouts that I have. If you have any general questions, you can always email me at dme@mdanderson.org. So from the Department of Medical Education, thank you. Does anyone have any questions? Yes. I would say that across the U.S., in general, most of the programs will have those same requirements. They may vary slightly, and again, we would encourage applicants to contact those programs directly to find out exactly what the requirements are for that specific program.
Sorry, I didn't introduce myself. I'm Dr. Abdullah from Mafraq Hospital. I have just finished my residency training in internal medicine, and I'm planning to apply for a fellowship abroad. At the moment, I only have a Arab board awarded for part 1, and in the process of applying for my part 2. But for the U.S. Emily, I'm in the process of applying for that. So is there any sort of like exceptions for those applying for residency or fellowship to the U.S. from the United Arab Emirates based on their Arab board results. Would you be accepting those?
I would say that if you're applying to an ACGME accredited program in the U.S., that you will need to have ECFMG certification, and you will also have to pass the USMLE steps 1, 2, and 3 in order to practice in the U.S.
صراحة المجهود اللي بذلتوه مجهود جدا طيب. أحب أشكر سعادة محمد خوري على المجهود اللي بذلوه في تنظيم هذا المنتدى، والله يطول عمر الشيخ منصور اللي دائما هو راعي مبادرات، وبالتعاون مع MD أندرسون ويونيفرسيتي اوف تكساس ومايو كلينيك بيعطي فرصة للمواطنين أن يدخلون في مجالات خارج الدولة تنفعهم وترفع من خبرة أبناء الإمارات دولة الإمارات العربية المتحدة.
So I think the healthcare industry is really a fascinating area, and there's a lot that's going on that's transforming what's going on today, and our administrators have to evolve with that change, and there are many opportunities to explore to facilitate that transition throughout an individual's career. I think students need to be tapping into these resources that are available to them. I think a lot of people aren't necessarily aware that there are these different options out there for them to pursue. So creating more awareness, I think, is part of our objective here today, and making sure that people get access to these programs wherever possible so that they can have the same opportunities that other individuals may already be accessing and have.
I think it's a wonderful opportunity to share ideas and see if we can globalize healthcare education. I think the idea that each country tries to recreate the wheel in their own way is not effective. I think the more we can bring nations together and share the educational burden for our physicians, I think the better off we'll all be. So I think this is a wonderful attempt. More of this needs to be done across multiple countries. The students' activity in this event was difficult to see from my point of view at the podium. I know that they're all here. I think their ability to engage earlier in training in the U.S. would be advantageous, and I think the sooner they can get in and sooner they can understand what it takes to train in the U.S., the more likely they will be to pursue it.
Yeah, my assignment today was to talk about eligibility criteria for gaining admission into U.S. residencies and fellowship programs. So hopefully today I shared some information that could lend towards anyone who might be interested in doing residency in the U.S. We are here to create some opportunities for Emirates to come to America to do observership programs. And so hopefully today I shared some information about that. So we do have a couple of opportunities through a STEP program, which is like an appointment of 5 days or less. And we also have an opportunity for applicants to come for longer periods of time, up to 90 days. They can do rotations through MD Anderson Cancer Center through various programs.
Well, we've enjoyed coming here. We enjoyed being guests of the Khalifa Foundation and Sheikh Mansour bin Zayed. This was an opportunity to discuss the Mayo Clinic and our opportunities there, our culture, and we found the audience very sensitive, knowledgeable, and hopefully there will be some good feedback, and maybe some of these people will come and visit us.
Yes, as a representative of education at Mayo Clinic, I very much enjoyed the opportunity to visit with colleagues in Abu Dhabi and across the UAE, and we're very interested in understanding ways that we can better educate one another using a variety of resources and look forward to further talks in how we can advance in that area.
I've come to Abu Dhabi to interface with the Khalifa bin Zayed Foundation and talk about how do we improve education in oncology here in the UAE. We have a lot of high-quality training programs in MD Anderson, and we're talking and trying to see if we can set up collaborations between young physicians here in UAE to perhaps come for additional training in the United States at our institution and just help improve the oncology care and really make it world-class in Abu Dhabi and throughout UAE. That's really the purpose of our visit. We're going to talk about a number of different ways we might do that with conferences here in UAE, with expertise content from our center, and having Emirati medical students and graduates come for additional training at our center and other centers in America, and then to come home and really provide outstanding care to the people here in UAE.
دعينا اليوم لحضور المنتدى الطبي المشترك عشان نعرف الفرص المتاحة لنا ما بعد التخرج. كطالبة سنة أخيرة يهمني أعرف شو الفرص المتاحة لي، ويهمني أعرف شو التخصصات المطلوبة في الدولة، وشو المطلوب مني إذا أبى أدرس في الخارج أو إذا أبى أدرس هني. المفروض أن يكون عندنا منتديات طب مشتركة أكثر لنعرف عن جميع التخصصات.
دعينا هنا لمؤسسة خليفة النهيان للمشاركة في المنتدى الطبي المنتدى الطبي. هل المنتدى يسمح للطلبة أن يشوفون فرص الدراسة المستقبل أو مواصلة دراستهم في أي مجال أو أي تخصص ممكن الطالب الطب أو الدكتور مستقبلا يفكر فيه؟ هل المنتدى بيسمح لنا أن نشارك فيه، نشوف الفرص المتاحة، نستمع لآراء الدكاترة المشاركين فيها؟ وبالنسبة لنا الشيء السبيشال أو شيء خاص في هالمنتدى أنه بيكون مشاركة من الولايات المتحدة. بنسمع لرأي جامعة تكساس أو الدكاترة اللي هناك بيشرحوا لنا شو الفرص المتاحة لنا. اللي يستفيد منه أنا كطالبة أني أنا بسمع آراء الدكاترة بخصوص الطلبة أو شو المواجهات أو شو التحديات اللي ممكن نشوفها مستقبلا، وهالشيء بيعطينا حلو فرص أن نفكر فيها من الحين لين عقب سنة أو سنتين نفكر مستقبلا بالخيار الأصح. أنا كطالبة هني باخذ فكرة، باخذ معلومات، وإن شاء الله بشارك ربيعاتي أو صديقاتي في الكلية أو أي حد ممكن يكمل مجاله في الطب مستقبلا في أمريكا، بشاركهم المعلومات. هذا باختصار.